welcome to the debate. Imagine a medical device that gets its primary diagnosis wrong 39% of the time, causes massive hospital-wide alarm fatigue, and regularly prompts completely unnecessary emergency heart catheterizations.
Right. And now imagine that exact same device is somehow considered the absolute gold standard for saving lives in the ER.
Yeah, it's wild. That paradox really captures the tension in modern acute care right now. Today, we are exploring the evolving role and the actual reliability of automated ECG interpretation systems.
Exactly. And the central question we're debating is this. Is our increasing reliance on automated ECG algorithms actually enhancing patient safety by catching human error? Or is it compromising safety by introducing algorithmic blind spots and, well, a false sense of security?
And this debate emerges from a massive body of recent clinical source material. We're looking at multidimensional analyses of ECG failures, studies on telemetry alarm fatigue, and the latest research on deep neural networks.
But before we dive into the data, we want to address all the cardiac techs and clinicians out there in the field listening to this. We know how crazy it gets in the wards.
Absolutely, which is why you should check out our EKG Survival Pack and the free study guide linked below. And hey, make sure you hit like, share, subscribe, and tell us in the comments, are you spending too much time charting and documenting instead of actually caring for patients? Because we're going to get into that heavily today. Let us know your thoughts.
Yeah, drop a comment. So just to establish where we stand, I'm going to be contending that our current reliance on machine output, especially without expert clinical overreading, creates dangerous systemic risks. It strips away clinical context and leads to a massive documentation burden.
And I will be arguing that automated systems are an indispensable safeguard. Without them, human error in both ECG acquisition and interpretation is just frankly too pervasive. We need them to handle the sheer volume of modern acute care.
Okay, but let's look at that human error argument. You're saying we need machines because we are fundamentally flawed.
I mean, yes, we are structurally flawed diagnosticians. If you look at the systematic reviews, practicing physicians interpret ECGs with only a 68.5% accuracy rate.
Which is concerning, sure, right. But wait, even trained cardiologists only achieve about 74.9% accuracy. We suffer from cognitive overload, decision fatigue, you name it.
I don't disagree that cognitive fatigue is real.
But it's not just the interpretation, right? Humans introduce massive physical acquisition errors before the algorithm even sees a single data point. I mean, clinicians skip proper skin prep 35% of the time.
Yeah, the failure to exfoliate the stratum corneum.
Exactly. The dead skin cells act as an electrical insulator. It dampens the microvolt signals, introduces baseline wander, and worse, they place the V1 and V2 electrodes too high on the chest in 50% of cases, half the time.
Okay, but
automated systems, especially the new deep neural networks, achieve over 92% accuracy for major abnormalities. They don't get tired at 3 in the morning, they provide an objective baseline. Those error rates for humans are high, I'll give you that. But relying unquestioningly on automated outputs to fix them creates a really perilous dynamic. Let's look at the mechanics of the standard machine. About 39% of standard automated ECGs are interpreted incorrectly by the device itself.
39% for legacy systems, sure.
Right, but that generates incredibly high rates of both false negatives and false positives. Because these algorithms rely on rigid, linear voltage rules, they just lack physiological nuance.
But they provide a baseline.
A baseline that forces physicians to manually modify 31.3% of all automated reports. This gets right to our question for the audience. Are clinicians spending too much time documenting? Yes. They are constantly forced into the electronic health record to delete false ischemic calls.
While they're verifying the data.
They are playing data entry clerk. The machine cries, inferior infarct, because of a slight baseline shift, and the clinician has to manually delete it and then add in a missed diagnosis like a prolonged QT interval. Without clinical context, patient history, body habitus, the machine's absolute certainty misleads inexperienced clinicians.
Okay, let's isolate the variables here. We really have to examine where the breakdown in accuracy originates. Is it at the bedside or in the software? I argue that machines are unfairly blamed for poor human data collection.
Unfairly blamed?
Yes. Think of the 12 ECG leads like security cameras placed strategically around a building, right? To capture the full picture of the heart, each camera has to be mounted in an exact, standardized location.
Okay, the anatomical landmarks. Right. So if the human nurse mounts the V1 and V2 cameras on the second floor instead of the fourth floor, which happens in half of all ECGs, the algorithm isn't looking at the front door of the heart anymore. It's staring at the roof. But the machine doesn't know it's staring at the roof. That is the fundamental flaw.
The machine accurately reports exactly what it sees. If those leads are too high, they look down at the right ventricular outflow tract instead of the septal wall. Mechanically, this alters the vector of depolarization, creating a delayed right ventricular signal.
Which manifests as a false RSR prime pattern.
Exactly. Or an artificial ST elevation. The algorithm faithfully interprets that electrical vector according to its programming. That resulting false ischemia is a human failure. It's an acquisition failure, not a machine failure.
See, I look at that exact same scenario and I see algorithmic danger. Yes, the human mounted the camera wrong, but the machine amplifies that human error with absolute, documented certainty.
It flags the elevation.
But when that false ST elevation occurs, the algorithm doesn't print a warning saying, vector mismatch, suspect high lead placement. No, it blindly interprets the voltage and prints anterior STMI in bold red letters at the top of the page.
Because it's programmed to be sensitive to ischemic changes.
But that specific text carries massive psychological weight in a fast-paced ER. It triggers an immediate protocol-driven cascade. I mean, up to 72% of unnecessary cath lab activations are linked directly to ECG misinterpretations just like this.
Okay, 72% is huge. But
The machine takes a human error and turns it into a highly invasive, expensive, and risky surgical intervention.
But what is the alternative? Seriously, the machine is explicitly designed to be highly sensitive because the cost of a false negative isn't just an annoying alarm. It is a fatal, missed heart attack.
I understand the stakes, but
You cannot optimize an algorithm to simultaneously be perfectly sensitive to a true anterior STEMI while also perfectly ignoring human incompetence in electrode placement. If we just mandate rigorous anatomical rib counting training, literally feeling the angle of Louis, walking down to the fourth intercostal space, that false STEMI disappears.
that assumes an ideal world where overcrowded triage environments allow for perfect, unhurried rib counting on every single patient.
It should be the standard of care.
Of course it should, but we have to design systems for the clinical reality we actually inhabit. And that psychological weight of the machine's certainty doesn't just cause unnecessary surgeries in the ER, it causes a cumulative psychological fatigue that follows the clinician right up to the telemetry floor.
Ah, you're talking about alarm fatigue.
Massive alarm fatigue. This brings us to a huge structural problem: how these automated systems impact the daily cognitive load. Currently, automated telemetry systems are just drowning clinicians in an ocean of non-actionable data.
Well, they are monitoring continuously.
Yeah, but one pivotal study looked at a 2-month period and tracked 20,775 telemetry alerts. 87% of those alerts were intercepted as completely non-actionable.
20,000 alerts is a staggering volume, I admit.
87% were false positives, triggered by motion artifacts. A patient brushing their teeth or simply rolling over in bed, and the noise is the problem. Because out of all those thousands of alerts, not a single automated alarm for asystole, VTAC, or VFib actually resulted in a code team activation. Zero.
But again, you are looking at the volume of the noise instead of the capability of the filter.
The hypersensitivity creates a relentless cycle of defensive documentation. Nurses are pulled away from actual patient care to silence a beeping monitor, physically check the patient, and then document the false alarm in the EHR just to protect themselves from liability.
Right, the charting burden.
Yes! It trains clinicians to subconsciously ignore the alarms. They assume it's just another false positive, which blinds them to true crises. Look, the burden of that noise is real. I'm not denying the charting is out of control, but abandoning the automation is not the solution. Better human system integration is. In that very study you referenced, how were those 87% of non-actionable alarms handled?
They were intercepted.
Right. by dedicated trained monitor watchers. The hospital integrated a human oversight layer, successfully shielding the bedside nurses from 87% of that noise. Plus, you are heavily criticizing legacy systems. Legacy algorithms use strict voltage thresholds, like a rigid tape measure.
If the stent segment elevates by 1 millimeter, the alarm fires.
Exactly. But newer AI algorithms, specifically deep neural networks, operate entirely differently. They solve this exact specificity issue, but neural networks are notoriously opaque. They operate as a black box where even the programmers can't explain exactly which morphological feature triggered the diagnosis. In medicine, we need auditable logic, not black boxes.
The internal logic might be complex, but the clinical performance is highly measurable and auditable. Neural networks don't use a tape measure. They analyze morphological curves, pixel densities, and the relationship between all 12 leads simultaneously.
Like a human cardiologist.
Exactly. It's much closer to facial recognition software. It looks at the context holistically. Algorithms like the Queen of Hearts have been empirically shown to reduce false cath lab activations from 42% down to 8%.
Down to 8?
Down to 8%, while actually increasing STEMI detection sensitivity from 71 to 92%. The machine learns to recognize the artifact of a patient brushing their teeth and ignores it while catching subtle T-wave inversions. This directly eliminates that documentation burden you keep bringing up.
The promise of deep learning is definitely fascinating, but it still doesn't solve the fundamental psychological danger of handing diagnostic authority to a machine.
How so?
Let's look closely at the confidence-competence gap, especially down in ER triage. The single most dangerous aspect of automated systems is the false comfort they provide when the algorithm declares an ECG to be normal.
Well, normal usually means normal.
Not always. 75% of young physicians report fearing they'll miss an acute cardiac emergency, yet they feel incompetent in their own independent ECG interpretation, so they anchor to the machine. But computers routinely struggle with physiological confounding factors.
They struggle with the same complex confounders that human doctors do.
Yes, but the machine prints its struggle as a definitive answer. Take a patient with an electronic ventricular pacemaker. The pacemaker creates an artificial electrical spike, followed by a significantly widened QRS complex.
Right, which alters the repolarization pattern.
It essentially masks the underlying ST segment changes that would indicate a myocardial infarction. The machine is blinded by the pacemaker's voltage. The same thing happens with early repolarization. A benign elevation of the J point confuses the baseline measurements.
Okay, but
When the machine misses these subtleties and prints normal ECG, the inexperienced clinician accepts that reading as gospel. They document the machine's interpretation, check the box, and send a high-risk patient home to have a catastrophic event. It gives the provider permission to stop thinking.
The problem with that framework is that you're comparing the machine's performance to a hypothetical, perfectly rested master cardiologist. That's not the actual baseline of care on the ground.
I'm talking about basic clinical context.
But without the algorithmic interpretation, that same inexperienced clinician is statistically worse off. Yes, the computer makes errors with pacemakers, but studies explicitly show that in 41% of the cases where the computer was wrong, the human providers still failed to recognize the error themselves when reviewing the raw tracing.
Because of anchoring bias, the printed text tells them everything is fine.
decision support because we cannot expect a 100% expert overread rate in overcrowded triage settings.
So we just rely on the machine's guess?
We rely on its objective baseline. Triage has a strict goal of door to ECG in 10 minutes. When a junior clinician looks at an atypical presentation, say, an elderly diabetic female patient who presents with nausea and fatigue instead of crushing chest pain, human clinical suspicion is already falsely lowered.
Triage bias is real, I agree.
Exactly. The clinician might not even suspect a cardiac event, but a deep learning algorithm doesn't care about demographic bias. It doesn't know the patient is female or diabetic. It analyzes the electrical waveform objectively. It catches the subtle ischemic changes that a fatigued human brain overlooks.
That sounds incredibly efficient until you examine the administrative workflow it generates. You mentioned the 31.3% modification rate earlier.
Which AI is solving.
But let's break down what that means right now for patient care. When a machine overcalls an infarct, the physician can't just ignore it. Medical legally, they have to physically log into the electronic health record, pull up the encounter, strike out the automated interpretation, type in the correct physiological diagnosis, and sign it.
Well, yeah, that's medical oversight.
But this happens on nearly a third of all ECGs performed in the hospital. It is an enormous administrative burden. It forces highly trained clinicians to spend their limited time legally auditing an algorithm, rather than talking to the patient about their symptoms. It transforms the clinician from a healer into a data entry clerk managing machine hallucinations.
But that auditing process isn't a distraction from patient care. It is exactly what ensures patient safety. It's the human and the machine working in tandem.
Is it, though?
Yes, the machine provides the rapid, instantaneous first pass, flagging anomalies across thousands of data points a second, and the human provides the clinical context to verify it.
But if the human is spending all of their cognitive energy auditing the machine's false alarms on the telemetry floor and correcting false printouts in the ER, they are not practicing at the top of their license. The chart looks perfect, legally insulating the hospital, while the patient in the bed is neglected.
Look, we have to look at the trajectory of the technology. Deep learning systems are getting vastly better at highlighting why they are flagging an anomaly. They are moving away from the black box.
That remains to be seen on a wide scale.
But the data shows it. They are learning to ignore the baseline wander from a heavy breather, recognizing it as a respiratory artifact, and they spot complex T-wave inversions long before a human eye could detect the pixel shift. As these systems refine their morphological analysis, that 31% modification rate is going to plummet. The documentation burden will decrease organically.
Well, until we reach that utopian future of perfect neural networks, we have to deal with the present clinical reality. And the present reality is that relying unquestioningly on the algorithmic text at the top of an ECG printout is a massive liability.
It shouldn't be unquestioning.
Right? It requires clinicians to actively maintain a skeptical framework. If the machine says acute ischemia, but the patient is a healthy 20-year-old with no symptoms, the clinician must have the foundational training to recognize the high J point of early repolarization or a high V1, V2 placement.
On that specific point, we are in absolute alignment. Foundational training in physical acquisition cannot be outsourced to software.
So let's summarize where we've landed, based on the evidence today. My stance remains that unchecked reliance on algorithmic interpretation inherently strips away vital clinical context.
Even with advanced AI,
Especially when legacy systems are still everywhere. By applying rigid linear voltage rules to complex human physiology, these systems generate dangerous alarm fatigue, forcing clinicians into an exhausting cycle of defensive documentation. Furthermore, they generate dangerous false comfort, that confidence-competence gap, when the machine misses subtle pathologies masked by confounders like pacemakers.
fair points.
Until these systems can reliably incorporate the actual physical presentation of the patient, they will continue to prompt inappropriate medical interventions and distract clinicians from bedside care. And again, to our viewers in the field, let us know in the comments if you feel like a data entry clerk.
Great summary. And my position is that automated systems, particularly as they evolve into sophisticated deep learning models, are totally vital to counteract the alarming rates of human error. Humans fail structurally. We fail at physical electrode placement, and we fail at complex pattern recognition under the stress of acute care.
We are fallible.
Exactly. The machine, while imperfect, serves as an indispensable, tireless safety net. It analyzes waveforms objectively, stripping away the demographic biases that cause humans to miss atypical presentations. It is a tool that, when integrated with human oversight, catches events that human fatigue would otherwise miss.
Well, we certainly have several points of convergence here. We both recognize that legacy, rule-based interpretation algorithms are deeply flawed and produce an unacceptable volume of noise.
Absolutely.
We also completely agree that rigorous standardized training in proper physical ECG acquisition is essential. Anatomical rib counting, proper skin preparation to reduce electrical impedance, poor input data ruins everything. Garbage in, garbage out.
Precisely. The complex intersection of human clinical judgment and artificial intelligence is not a zero-sum game. Achieving the highest standard of patient safety means acknowledging the specific fallibilities of both humans and machines.
They compensate for each other.
Right. The machine lacks clinical context. The human lacks absolute consistency and tires easily. The algorithm provides the rapid, objective baseline, while the clinician provides the contextual reality of the patient in the room. But this only works if we maintain the deep clinical expertise necessary to know exactly when to overrule the algorithm.
That is the challenge moving forward, ensuring that as the algorithms grow more sophisticated, we don't allow our foundational diagnostic skills to atrophy in their shadow.
Very well said. Thank you for joining us on The Debate.